respected chairpersons and dear colleagues. My topic is Community-Oriented Program for Control of Rheumatic Disorders, a WHO APLAR initiative. COPCOD was launched in the year 1981, and at that time it was divided in 3 stages. Stage 1 comprised collection of epidemiological data. Stage 2, education. And education means of education of the healthcare professionals, patients, and extended families. Stage 3 comprised etiological research into environmental and genetic risk factors and control of the risk factors with a view to reducing the burden of rheumatic disorders in the community. Stage 1. Stage 1 data have been completed in many countries in Asia Pacific, in Africa, and in Latin America. In the Asia Pacific, it has been completed in 17 out of 50 countries. This is the list of the 17 Asia Pacific countries. In the Asia Pacific region, the prevalence of total musculoskeletal pain was 24.2%, low back pain 10.3%, osteoarthritis 10.2%, and soft tissue rheumatism 4.8%. What are the achievements of stage 1 so far completed in Asia Pacific, Africa, and Latin America? The prevalence data have been collected and reported from 17 Asia Pacific countries and a greater number of countries in Latin America and in Africa. Commonest causes of MSK pain and resulting disability were low back pain, knee OA, and soft tissue rheumatism. The APLAR COPCOD investigators have experience of epidemiology, translation, and validation of the questionnaires. The major deficiencies of stage 1 were enormous data were collected but not reported. For example, help-seeking behavior was a part of the questionnaire but has not been reported by most of the COPCOD study groups. Disability data were similarly recorded but not great extent reported, and the prevalence of musculoskeletal pain sites, these things have been well reported. The prevalence of rheumatic disorders have not been reported that much. Burden of disease not estimated, and there was no concerted effort to collate data. Data repository. It was quite expected that since the work is going on simultaneously in many countries of the world, it was possible to develop a global data repository, but because of lack of such a planning, the repository were not developed. And now we cannot develop the repository with retrospective data since the data were not saved in electronic format. Early data were saved in non-retrievable format. For example, the first Asian study was performed in Indonesia by Dr. John Dharmawan, but the data were I would say saved in the mainframe computer in early 90s, or late 80s. So these data were not, are no longer retrievable. Data were not saved in a common template, and thus it made pooled analysis very difficult. What were the barriers to archiving? Majority of publications are not saved in electronic format. Journal authorities do not agree to give publications free of cost, and also there is lack of fund for this activity. Stage 2 was designed to be the stage of education, but I think it was somewhat like putting the cart before the horse, because with a view to educating the patients and the community, we must have validated data on the risk factors of the particular rheumatic condition. So putting education before identification of the risk factors, though it was possible to envisage at that time in 80s, but nowadays it is apparent that we should first identify the risk factors and then go for education. So my next slides are actually a bit more futuristic. What may be done next? Firstly, we should recognize that COPCOD should deal with the common problems. Prevention of onset, progression and relapse of the conditions should be the main aim. Non-specific low back pain, soft tissue rheumatism and knee OA were the commonest. Non-specific low back pain and soft tissue rheumatism are self-limiting but relapsing. The first episode best identifies the population at risk, giving us the opportunity for an intervention aiming at secondary events. And knee osteoarthritis is progressive, so we can prevent the progression if we have enough data on the risk factors for progression. So regarding stage 1, what I can do, for example, as I have mentioned earlier, in the Asia Pacific region, the prevalence, incidence, these things have been estimated in 17 countries, but there are many countries, out of 15, 33 more countries where these studies have not been performed. So we have to extend our, our stage 1 activities. How large? It means, leagues against rheumatic disorders like APLAR, APLAR and PENLAR, how they can help. These LARs may centrally design questionnaires to encourage new investigators. Investigators become more enthusiastic when they have, the basic things prepared at hand. Development of a uniform protocol, a common core electronic data sheet. It may help preserve valuable data, and also it facilitates, it encourages the, young researchers to carry out the studies. And also, this electronic data sheet may automatically evolve into a COPCOD data repository. And stage 2 and 3. My proposals are, the LARS should foster development of COPCOD questionnaire for identification of the risk factors for rheumatic disorders. Population studies may be carried out with the help of questionnaires for the identification of the risk factors, and the LARS also may fund for development of computer data template for entering data from the risk factor studies. Then, we may collate data from all the centers for precise identification of risk factors by pooled analysis if data are available from a core data template. Then the LARS may promote development of local educational modules on the basis of identified risk factors, and the local versions of outcome measures may also be developed for interventional studies. Field testing may be done with the modules in the COPCOD areas, and advocacy for mass education program may be carried out if modules effectively reduce the burden of MSK pain and RDs. So my conclusions are, structure of COPCOD is suitable for LMICs. COPCOD is an important showcase for the regional leagues. Attempts of the LARS at broadening their horizon may be spearheaded by COPCOD. The final success of COPCOD will lie in generating evidence-based, affordable behavioral intervention for the reduction of burden of MSK morbidities in the low and middle income countries. And this is the COPCOD website. You can go visit this website in the internet, and I thank you all for paying your patient heed. Thank you very much.